Hi everyone, I am Miss Deepika, Assistant Professor from the Department of Nutrition and Dietetics from St.Josephs Arts and Science College for Women, Hosur. Here we are going to discuss about diabetes insipidus. Introduction. Diabetes insipidus is not the same as diabetes mellitus. Diabetes insipidus is an uncommon disorder that causes an imbalance of fluid in the body. This imbalance leads to produce large amounts of urine. It also makes very thirsty even if we have something to drink. Diabetes insipidus occurs when the body can't regulate how it handles fluid. The condition is caused by a hormonal abnormality and it's related to diabetes. In addition to extreme thirst and heavy urination, other symptoms may include getting up at night to urinate or bedwetting. The word diabetes means to go through, describing the excessive urination. Insipidus means the urine is tasteless, whereas mellitus suggests it is weak from its sugar content. Diabetes insipidus. Definition. Diabetes insipidus is a disorder of the posterior lobe of the pituitary gland characterized by the deficiency of antidiuretic hormone, which is called ADH or vasopressin. Great thirst, which is called polydipsia, and large volumes of dilute urine characterize the disorder. Diabetes insipidus, which is called DI, is defined as the passage of large volume greater than 3 liter per 24 hours of dilute urine lesser than 300 mosm per kg. Pituitary gland. Types of diabetes insipidus, which is called DI. Totally, there are two types of diabetes insipidus. The first type is central diabetes insipidus, and the second type is nephrogenic diabetes insipidus. Central diabetes insipidus. Central diabetes insipidus is a form of DI that occurs when the body has a lower than normal amount of antidiuretic hormone, which is called ADH. ADH is also called vasopressin. ADH is produced in a part of the brain called the hypothalamus. ADH is then stored and released from the pituitary gland. Nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus occurs when there is a defect in the structures in kidneys that make kidneys unable to properly respond to ADH. The defect may be due to an inherited or genetic disorder or a chronic kidney disorder. Causes. Causes of central diabetes insipidus: head trauma or surgery, pituitary or hypothalamic tumor, intracerebral occlusion or infections. Causes. Causes of nephrogenic diabetes insipidus: systematic disease involving the kidney, multiple myeloma, which is a cancer that forms in the type of white blood cell called a plasma cell, sickle cell anemia, Polycystic kidney disease, which is an inherited disorder in which clusters of cysts develop primarily within kidneys, causing kidneys to enlarge and lose function over time. Kidney infection, medications such as lithium. Pathophysiology, central diabetes insipidus, loss of vasopressin producing cells causing deficiency in antidiuretic hormone, which is called ADH, synthesis or release. Deficiency in ADH resulting in an inability to conserve water, leading to extreme polyuria and polydipsia. Nephrogenic diabetes insipidus, depression of aldosterone release or inability of the nephrons to respond to ADH, causing extreme polyuria and polydipsia. Signs and symptoms: polyuria with urine output of 5 to 15 liter daily, polydipsia, especially a desire for cold fluids. Marked dehydration as evidenced by dry mucous membrane, dry skin, and weight loss. Anorexia and epigastric fullness, nocturia, and related fatigue from irregular sleep. Diagnostic test for diabetes insipidus: high serum osmolality, usually about 300 milliosmol per kilogram, MOSM per kg of water. Low urine osmolarity, usually 50 to 200 MOSM per kg of water. Low urine specific gravity of less than 1.005. Increased serotonin and blood urea nitrogen, which is called BUN, levels resulting from dehydration. Positive response to water deprivation test. Urine output decreases and specific gravity increases. Goals of management. The objectives of therapy are to replace ADH, which is usually a long term therapeutic program, to ensure adequate fluid replacement, to identify and correct the underlying cause. Treatments: replacement vasopressin therapy with intranasal or IV DDAVP, desmopressin acetate. Correction of dehydration and electrolyte imbalances. A thiazide diuretic to deplete sodium and increase renal water reabsorption. Restriction of salt and protein intake. Thank you.